All right, moving on to this case. Moving on to this case, we have the global finding here of an ulcer. And what I want you to be able to make out is that this ulcer is not in a random array. It's in a retiform array. Retiform meaning net-like. So you're getting this retiform array that's causing an ulceration. And whenever you see a retiform ulcer like this, it's because the blood vessels to the skin are getting disrupted in some way. So the skin is dying because the blood supply, the water, if you will, the blood vessels to it underneath are getting screwed up. So again, no one's going to look at this and say, oh, this is X, Y, or Z, but you're going to look at this and say, this is a retiform purpura, retiform ulcer. This is something bad, something screwing up the blood vessel. There's really great reviews out there in terms of tackling retiform purpura. My favorite is a 2020 JAD CME, where it goes through it. And basically, the way to think about it is when you get retiform ulcer like this, it's got to be something that's either screwing up the outside of the blood vessel or inside. Outside, you think about depositional, calcium or oxalate. So calcium deposits in the outside of a blood vessel, we call that calciphylaxis. Other things that can cause outside deposition would be infection. If staph is going in, if Pseudomonas is going in, we call it ecthyma gangrenosum, etc. So deep fungal, deep staph, deep pseudomonal infections. And the last thing is vasculitis. If you have inflammation of the blood vessel wall because the patient has polyarteritis nodosa, that can give you this. And then the other category is going to be stuff that's screwing up the inside of the blood vessel, and that's thromboembolic. So thrombotic is, do they have a primary coagulopathy? Is it livedoid vasculopathy, or do they have known protein C deficiency? Embolic, unlikely to be embolic like this. When someone's showering emboli, it's usually going to be distal small blood vessels. But again, is this an IV drug user? Is this a patient who has known endocarditis? Other reasons for developing emboli. Once you break it down in those pathways, it's really not that intimidating. You think about it like that. You think about the labs and workup you have to do, which I won't go through right now, to work those up, and you do biopsies. And this was calciphylaxis. This is a young woman, I believe ambulatory, not in consults, presenting with numerous studded pustules all over the forehead and cheeks. And I really like this Kodachrome because when you get just thousands of monomorphic minute pustules like this on the forehead and face, there's not much that can look like this. And I want you to know that this probably is always going to be Demodex, and this is Demodex folliculorum, just a overgrown, crazy form of rosacea that can develop, and that's what this is. And you can think about other things here like pomade acne if someone's using something really occlusive, acute localized exanthamatous pustulosis. It's hard for me. Pityrosporum maybe. Hard to expand a differential. Really, when you see these many minute pustules, it's almost always going to be Demodex. It's very satisfying. Just pop one of these, put it on a slide. You'll see the little barbell looking organism, and then you know what it is. Here's a cool case of a patient I saw in clinic. What are you seeing here? Note that the interpapillary gingiva are markedly overgrown. So you have marked overgrowth of gingiva. So this is gingival hyperplasia. We learned in derm that this is usually due to cyclosporin or phenytoin or some other things like that, calcium channel blockers sometimes. And so this was a patient who was actually on long-term cyclosporin. I think one way you can actually get that Kodachrome, if you're really astute, is to look off to the side. Note that this patient has gingival hyperplasia, but she also has hirsutism. So look at these fine hairs that are pretty excessive growing off here, and that's why I really like this Kodachrome. So you can see excessive kind of pink to blonde hair, some terminal hairs here, as well as gingival hyperplasia. Tells you this is almost certainly cyclosporin. And this is a patient who's on long-term cyclosporin for aplastic anemia. She's actually done very well. We're treating her with chlorhexidine washes and azithromycin, and she's actually almost completely remitted her gingival hyperplasia. It's very satisfying. This is a patient in the hospital who's presenting with this painful cord. I really love this diagnosis because when you make this diagnosis, you just feel awesome. You just look like a rock star. And what are you seeing here? Look at this linear reddish-brown cord. You can see it extending from the forearm onto the dorsal hand. You can almost trace a perfect line around it. It's warm, it's hot, it's tender. You palpate it, it literally feels like moving like a snake or a hose underneath the skin. And this is superficial thrombophlebitis. So this is where a superficial vein gets clotted off basically histologically and gets really inflamed, often due to an IV site, being around an IV site, which is a clinical clue here. And the way you diagnose it is you have the patient get an ultrasound. You don't have them scan their deep veins, but their superficial veins, and they'll find the clot. And then you treat it with topical steroids and NSAIDs, things like that, and it goes away on its own. All right, couple more slides.